G'day, my name's Ian Stevenson. I'm a consumer with a lived experience of mental distress, but I'm also a filmmaker. And I was asked to make a film about a group of clinicians and carers and consumers who formed a dual diagnosis advisory council and out at Eastern Health. And they formed this council over 10 years ago. And they've had some great successes, and they've had their failures, and they've had their ups and downs. And this film is really a celebration of all that, of kind of how they got it to work and some of the pitfalls, and you'll get to meet some of the faces and some of the personalities on both the clinician side and the consumer carer side. This is a really uplifting story, I think, about how people with lived experience, whether they're carers or consumers, can add a real dynamic voice into the dual diagnosis space, or any clinical space for that matter. I hope you really enjoy the film and get a lot out of it. I got a lot out of just filming it, and I learned a lot about dual diagnosis. Let's keep exploring ways to bring in the lived experience voice, and I hope you enjoy this film.
My name's Gavin Foster, and I'm the manager of the dual diagnosis and service development out of Eastern Health within the mental health program there. I've been involved with the Dual Diagnosis Consumer Care Advisory Council and the Dual Diagnosis Working Group since it began over 10 years ago now. And at the time, prior to it starting, I was working with a group of alcohol and drug and mental health staff members who were really quite interested in exploring how to get the best consumer representation of the consumer and carer voice in working with clinicians and practitioners.
10 years ago, I was the manager of drug treatment at what was Knox Community Health. And we worked in partnership with Gavin Foster at Eastern Health and the team there. And it was a really exciting time of collaboration. So mental health services, AOD services working seamlessly together. And the vision was to create a service system that was seamless, that the person coming for help would really get their needs met no matter what they were, whether it was mental health or housing or drug treatment.
Yes, I'm seeing somebody for my drug and alcohol, I'm seeing somebody for my mental health, and I'm going to my GP around my physical health. And I've got a chaotic life, trauma history, and I'm trying to juggle addiction and severe mental illness. And you want me to turn up to 3 different appointments in 3 different service systems? Then people go to see they're not cooperating. They've dropped out of care. They're not willing, they're not motivated. It's not that they're just not capable right now. And I think we underestimate the chaos that operates within somebody who's struggling with addiction and mental health.
A lot of AOD workers were just, in counselling their clients and so forth. They had to deal with mental health issues, but a lot of them didn't have, a lot of training. And certainly at that point in time, consumers, carers in the AOD sector didn't have a really big voice.
So I actually went and had a meeting with the consumer consultant and a carer consultant out of the Eastern Health Mental Health Program. They actually said to me that it didn't really work just having one person representing a consumer and carer voice, that often they could do a good job. But in fact, it worked better if there was a group of people who were actually able to represent the consumer and carer voice within any kind of mental health and alcohol and drug conversation.
I guess the vision that the dual diagnosis team had was to really ensure that the person coming for treatment was included in the planning. And so we started toying with the idea of an advisory group.
An expert, committed group of consumers and carers who are accessible and engaged with a senior leadership group means that we're able to utilise those skills and expertise in a way that makes for a better clinical service.
We became involved in a working group that was being, I suppose, auspiced by Eastern Health at the time, and Gavin Foster had been responsible for setting up that group. And I guess what was really, I suppose, remarkable and lovely about that group was that it involved a whole range of agencies.
So the idea was that we would really work hard, having had that advice about setting up a group or an advisory group, that we would work pretty hard on actually getting a group of consumers and carers with lived experience of dual diagnosis.
So each of the metropolitan and a number of the regional areas also got funding to establish these advisory councils with varying degrees of success. We followed the model, Nexus followed the model very similar to Easton. So we set up a recruiting, advertising, interviewed people and established a council, very much 50-50, half carers, half consumers. And we ran for 2 years while the funding was still there.
I don't know. I mean, we were practicing co-design, I think, before that became a real buzzword.
And being able to utilise that group to help us with developing services, with critically reviewing the services that we're providing and providing us with that level of expertise from within the program is really unique. And I think it's something that I haven't experienced before.
The success of our 10 years of the council's activities on 3 key principles: learning together in this journey in the dual diagnosis space, having a shared expertise about how we go about doing things. We bring our personal experiences and knowledge and skills, and we blend those together into our council activities.
Since coming here, I've always known and seen how the DDCAC are able to really contribute to the development of our service.
My father passed away, and that was the hardest thing. Yeah. In between that, my mother, she abused alcohol, abused pills, had a mental illness. Now, all through my life, I was continuously going to funerals after funerals in my teen years. And then as I got into my 20s, it was happening again. I was going to funerals and funerals and funerals. And every time I go to a funeral, I'd say to myself, that's it, I'm quitting the piss. That's it, I'm going to be clean living. I'm going to do what I do. However, that would spiral out of control. I'd have moments of madness and just wander off, bloody pack my bags and go. I wouldn't hang around. Now, learning to ground myself, on them days I just didn't know how to ground myself.
They call it Bluestone College because of the bluestone walls here. I was never a smart ass in there, you know. It was I was like a bit of a sheep. Now this looks very familiar, viewers. Follow me. This is where drugs and alcohol took me. The notorious A division. Now, just follow me and I'll see if I can, this is 30 years ago, I say, so I've got to recollect a bit in the brain. Now, they're the cells up there, see the cell windows? That's the only access I had to natural light once the doors were shut, which was 4:30 at night or in the afternoon.
start to treat my son as a friend and understand what he's going through. Just let things go, and I know when to step in and when to step back, and encourage their family to call the helpline to talk about what they're going through and their struggles. And if the family choose to seek help, they will change and they become different people. The way the consumer is struggling, the way it's exactly the same way the family struggle. Because when the person unwell relapse, it dragged down the whole family with them, especially the carers. July 2015, I lost my son to suicide.
Well, in the beginning, I felt I was very angry. I was very negative. You know, I had to do so much navigating. Everything was left to me to do as a carer. I was a forgotten about individual in recovery, and I really had to fight to get anywhere or find any assistance. So I was very negative, and everything I spoke was doom and gloom.
The work between FAPMI and the council has meant that more and more thinking about families is happening in the dual diagnosis space. So we're seeing parenting being considered and children being considered, and that's all part of the recovery for people who are coming into our services. What we know is that parenting is a really big motivator for change and for recovery, and so FAPMI working with the council means that we can develop resources that staff and services can use, and we've also given people some ideas about having those conversations with parents about their kids and about what that might mean for their treatment.
So I have a lived experience of being a consumer and also in mental health. So I've plodded my way along through life, not quite knowing how to deal with symptoms and problems, and being able to find good doctors, good supports, mental health, medication, a number of different things that have actually built me to a spot where I can do this role. Everyone has their ups and downs. It's the way we manage our problems, and that we need to be kind to ourselves when we are going through struggles. It's not easy, and sometimes we need supports and help in order to get where we want to go.
But over, I'd say, the last 8 years, this is where the actual basis of the council became quite stronger. The team that came together have actually stayed together for quite a bit over that time, and it's been a supportive group, and it's grown.
There were certainly arguments. I remember two in particular that it nearly ended up in the car park, and I was involved in them both. But we just got on with it. We did care for each other, but because we were all had a history, and the carers in the group knew such behaviours because they either lived with them directly or were caring for someone in their circle, could understand. So it was a lot of good communication.
We have a council meeting followed by a working group meeting, and both meetings have the same agenda. Prior to those two meetings, the council members themselves have a reflective practice session, which just gives them an opportunity to meet together as a group, to chat about any issues of importance to them in their work in the council.
We actually ask people to work with us because of their lived experience. One of the joys of actually doing this work is actually seeing people kind of go through this growth. But there are times when, as the leader for this activity, that I've had to really have a look at what's going on here, and particularly if a person started to relapse or to maybe go back towards substance use for particular reasons. We've had to start making calls around how to support that person and how to make sure that just because that's happened, that doesn't mean the end of working with us. It means that maybe the clinicians in our group need to use their skills, their expertise to actually support that person to get through that.
The 10 members of the Consumer and Care Advisory Council and the mental health professional team, the dual diagnosis team, which is called the Mental Health Working Group, have created the council based on what we call the in tandem model. This is a bit like riding a tandem bicycle, that the council members come together with the working group once a month to meet together to work through an agenda of items and to plan activities going forward. The workload shifts according to the kinds of activities that are being actioned at any particular time. Gavin Foster and the Mental Health Working Group may take the lead at times, and definitely the council members will be taking a lead at other times.
I joined the Dual Diagnosis Consumer and Carer Council back in 2018, following alongside of my recovery. It played an extra beneficial aspect to my own recovery of dual diagnosis. I just wanted to start helping other people on their journeys to recover. When I read the values and the code of conduct relating to the Dual Diagnosis Council, that really gave me a sense of security that they place the same values that I do.
We realised there was a need for people in the clinical mental health program at Eastern Health to have a way of connecting around their dual diagnosis, and that often the case managers weren't really connecting with people in the way that they needed them to. So they needed a more group-focused environment. So we started a group program in 2006, and it was run by staff at that time. And actually, as a dual diagnosis senior clinician, I basically ran the group and had staff come and help me. So that would educate them about dual diagnosis. We thought, wouldn't it be great if we could have people with a lived experience actually coming into the group program who understood dual diagnosis, who could relate, but were in a good point in their recovery journey to be able to put some input in.
The IPU is the inpatient unit, the acute mental health and addiction ward. So me and my co-worker, we go in there once a week and we facilitate a group, and it's a peer support group. We've got a whiteboard, and the clients in the hospital, they attend these groups, they sit down, there's probably up to 15 people, and we talk about, we initially start off with our stories about our addictions and our journeys in life. Then usually the clients that are sitting in this group, they talk about their addictions to drugs and to alcohol and gambling and other addictions. So then we've got a common bond together. Then we come up with solutions on how to deal with our addictions and our mental health.
And one of the positives that I see being part of the group program is the feedback we get from staff. You go back to the ward the following week, staff member comes up and says, so-and-so and such that was at the group last week has really interacted well with the clinical staff, the nurses, the counsellors, psychiatrists, psychologists. And that's a really powerful thing. So
Tony and I won't necessarily see that during the groups. Dual diagnosis is about telling the patients that there's a new system, a changed system, an improved system, where there's no discrimination and stigma and condemnation. If you say to the staff, I've got a mental health problem and I've got a substance use concern, but I'm one person, can you treat both?
And that's what we try to offer people when we see them in the various inpatient units. We offer a supportive and safe place to share their story if they want to, and to have that empathy and understanding for what people are going through, and to offer, I don't like the word hope, but a way out.
It turns out over the last few years, since the group program has been running weekly, that we have 2 members of the council attending the same group each week, and just for convenience and good planning purposes, it turns out that most groups have the same 2 consumer and carer members attending each week.
What has been driving me in this space are 2 things. One is I know that we need to do this whole dual diagnosis thing so much better than we are. So we need to work in the co-occurring mental health and alcohol and drug space much better. The other part for me is around the impact of the consumer and carer voice in the delivery of our services. And this is, in some ways, whilst we've had it going for maybe 10, 15 years now, maybe even longer in some areas, we haven't really explored the full complement of activities and ideas that we can have with the lived experience workforce.
Thinking about what it was like 10 years ago, I guess it's really interesting how hard it's been to get a consumer advisory council happening, really, because when you think about it, you know, it's kind of like democracy. You know, people have rights. People have rights to participate in their healthcare, and this is healthcare. This is, you know, a health issue. But because it was drug use, or because it was mental health, it was such a stigmatised issue. And I think there was a lot of fear in service providers that if we have an advisory council with consumers, you know, they're going to take over, or they're going to ask for things that we can't deliver.
But there's a committed group of people out in the eastern area that seem to have really stayed in there, even after they've gone well into the recovery. I think they've enjoyed the process, and I think there's a culture and a dynamic in that group that is kind of really welcoming and inclusive. And I think that's been the strength of it. Belle Groves, who is our most recent representative, talked about being able to sit in and listen to and hear all the other stuff that's going on at a service and a systems level really helps them shape their thinking and the emphasis of where they put their work.
Council members are also involved in a range of other activities outside of the immediate Eastern Health region. For example, our council chairperson attends the leadership group meetings of the Victorian Dual Diagnosis Initiative, and that's a valuable connection to have with the leadership group that functions right across the state of Victoria.
There is a bit of protection of turf in sectors when it comes to consumer voice, certainly in those days. And it's exciting for me to know that this is still going 10 years later, because it was cutting edge. I'm still surprised it was cutting edge then. I'm kind of hoping that it's really going to take off to be the norm. to see it as a human right, to see that service providers have to be working in partnership with people who have a lived experience, and it's that their right to talk about what they need from the service.
Where I am standing now and what I am doing, it's because of my son. I've learned from his journey and my journey with him. My journey to speak up and to always fight and advocate on behalf of the carers and the consumers, and trying to spread awareness so other families and carers don't stand where I am standing.